For the next half hour or so, I'm going to go through, as much as I can in half an hour, what we do when we look at a mammogram and we see a mass on the mammogram and how we decide what to do or what not to do about it. When I talk about an analysis of breast masses, what I'm really talking about is analysis primarily of a single dominant mass that we see on a mammogram. So those mammograms that you get that have 50 or 60 bumps on them is not really what it is that the focus of this talk is going to be. The evaluation of the solitary breast mass involves an assessment of the sharpness of the margins of the lesion, the shape of the lesion, involves an assessment of the location of the lesion in the breast, first of all, so that we can describe it on the report, and secondly, because every lesion that's on the mammogram is not really in the breast tissue, of course. Some of it can be in the skin, some of it can be in the subcutaneous tissue, some of it may be up in the axilla. An evaluation of whether there is or is not associated calcification, the effect of the mass or the suggested mass on adjacent structures, the presence of the secondary signs of malignancy that we look for, associated findings that may or may not be present on physical examination, the clinical history, and of course, if we do a sonogram, the sonographic findings. The secondary signs of malignancy are those signs of breast cancer that are incited by the tumor mass itself but are not actually the tumor mass. And they include disruption of the adjacent architecture in the breast, alteration in the size or configuration of the skin thickness or the nipple, the presence of skin thickening, the presence of axillary adenopathy, and the presence of a prominent draining vein. The presence of these makes us more suspicious when associated with a solitary lesion that what we're looking at is a cancer. When we are assessing a dominant mass on a mammogram, of course, the whole point of it is to decide what to do about it, not so that we can describe something and end the report there. The mammogram, when we do a mammogram on a patient, it makes the patient our patient, and the decision, I believe, is our decision. And it's important to always remember that masses that are definitely benign require no further evaluation. If you know it's not clinically significant, you don't have to do anything more about it. However, it is common not to be able to differentiate a benign mass from a malignant mass because the findings on the mammogram are very nonspecific in many instances. The degree of concern that it may be malignant determines how each lesion will be further evaluated. And the options that we have include sonography, a short-term mammographic follow-up, or tissue sampling, if we cannot determine that something is definitely benign, in which case, if it is definitely benign, she just goes back to the routine screening setting. Now, the American College of Radiology, in its lexicon, has set up a series of descriptors to give some uniformity to the mammography report, firstly, and secondly, and I think perhaps even more importantly, to tell us what words we need to go through in order to train our eyes so that we make the appropriate assessment of a lesion on mammography. And I think if you use the right words, or if you force yourself to use a limited number of words, the words that you choose, if you listen to them or if you look at them after you're done choosing them, will actually tell you what it is you need to do with the lesion. The ACR lexicon vocabulary for this includes, first of all, the definition of a mass versus a density. A mass is something that we see on two or more views. A density is something that's only identified on one view. So it may be there or it may not be there. It needs to be worked out in terms of whether or not there's actually something there. Then we need to describe its shape, its margins, its density, the associated findings, and the location in the breast, just as we've already talked about. Carcinomas have a very wide spectrum of mammographic patterns. It is very important to always remember that the likelihood of a lesion being malignant increases as the marginal irregularity increases. Now, when we describe shape, the words that we use to describe shape include round, and round is pretty straightforward. Oval, which is squished round, and that's pretty straightforward. Lobulated masses have these reasonably prominent, rather large bumps in them. And it doesn't have to be a whole bunch like we see on this image here. It can just be one little bump there, making it lobulated. Irregular makes this a kind of scruffier pattern, as you can see here, and is going towards architectural distortion. Modifiers of shape include whether or not a lesion is circumscribed, that is, whether we see all its borders nice and sharply on all the views that we have of it. Microlobulated, which is this kind of finer, bumpy pattern. Obscured, which means that we see much of the lesion, and much of what we see is circumscribed, but there's a portion of it which has adjacent, what looks like adjacent normal breast tissue, which silhouettes out part of its margin, something that I think all of us commonly see on nodules on a mammogram. This is as opposed to indistinct, and indistinct is where we can make the determination that the mass itself has a fuzzy margin. Part of that margin is not well defined. So it's not the adjacent tissue that's silhouetting it out, but it's the mass itself which has blurred out because of this extension to adjacent tissues. And then there is spiculated. You'll recall that it's spiculated now. It's not stellate anymore. Spiculated, which is this jagged, crab-like, grossly irregular looking pattern that you're all familiar with. Now, we also describe density. And density is described in terms of how dense the lesion is as compared to the normal glandular tissue in the breast. So there's high density, there's isodense or equal dense, there's low density but not containing fat, and then there are fat-containing lesions. Increased density versus the normal glandular tissue may be seen with both benign and malignant processes and is nonspecific. Increased density, however, is not consistent with just normal glandular tissue in the breast. And cancers, of course, may be isodense, may have increased density, and in some may contain some fat streaking through them also. Now, there are a few special cases that don't fall into the descriptors that we've already gone through. And those include the solitary dilated duct, the inframammary lymph node, asymmetric breast tissue, and a smaller focal asymmetric breast tissue area. Now, well-defined round masses are considered benign because, or considered usually benign, because well-defined smooth margins suggest that the lesion is either a cyst or it represents a solid mass which does not invade surrounding tissues. Round or oval masses also suggest that the lesion is either a cyst or a mass which has arisen from a single cell which has duplicated in a controlled, organized fashion, making this round or oval structure. Irregular or ill-defined masses suggest that the process causing the mass is aggressive and has invaded surrounding tissues. Lobulation also is a suggestion that the duplication of the cells inside the mass may not be controlled, may be a little bit uncontrolled, and therefore has a characteristic which suggests the possibility that it is malignant. So the more irregular, the more lobulated, the less round and well-defined a mass is, the more it has characteristics suggesting the possibility of malignancy. So that's why the very accurate evaluation of shape of a lesion is pivotal in determining what it is that we're going to do in terms of any further workup of it. Now let's look at some special kinds of cases on mammography and some of what are unfortunately the few instances where we have a focal lesion on a mammogram and we can actually make a diagnosis of what this represents. First of all, lesions containing fat often are pretty easy to deal with. Lesions that contain all fat include lipomas or oil cysts or galactoceles. Lesions which are composed of soft tissue density, water density material, as well as fat include lymph nodes, hamartomas, hematomas, galactoceles, some infiltrating lobular carcinomas, asymmetric breast tissue, and some phylloides tumors. Masses containing fat are almost always benign if they are well-defined or focal masses. Hematomas and infiltrating lobular carcinoma can be poorly defined. Hematomas, however, are usually apparent on the basis of the clinical history. Everything that contains fat is not benign. There are some ill-defined masses that contain fat that will be cancers. But these well-defined masses, these well-circumscribed masses containing fat are benign lesions. And let's just look at a few of them. A lipoma is not an uncommon finding on a mammogram. On physical examination, it is usually a soft, kind of squishy lesion. They may be non-palpable, although I rarely call them unless there's something palpable on the physical examination. It displaces adjacent tissue, which is how we see it. It can either displace the surrounding dense glandular tissue, in this case, where this is the lipoma, or if you don't have a lot of this tissue, you'll just see the stromal markings in the breast being displaced. It's not associated with malignancy. It's not premalignant. It doesn't look like what a liposarcoma looks like. And when we see this corresponding to a palpable mass, we can make a definitive diagnosis of lipoma. Oil cysts or galactoseals look exactly the same on the mammogram. They are radiolucent masses. They look like this, or this, or this, or this. They look like what when my residents first look at a film, they look at them and they say, oh, it's a cyst. But it's not a cyst because it's fat density, it's not water density. There may be calcium within the wall of an oil cyst or a galactocele. An oil cyst is post-traumatic, and a galactocele is related to lactation, so it's on the basis of the history that we make the differentiation. On the 90-degree lateral film, you may in fact see a fat fluid level in these masses. Lymph nodes are very, very common. We commonly see them in the axilla and in the low axilla, and they can extend into the upper outer quadrant in the breast. Classically, they have a kidney bean-shaped configuration to them with a fatty hilum, and they're usually located in the upper outer quadrant. And here you see that bean shape with a little fatty hilum there. Axillary nodes may be seen in the same mammogram, or they may not be. So you don't have to see nodes in the axilla in order to call an intramammary lymph node. The density approximates that of glandular tissue, and these are not of clinical significance. Hamartomas are unusual breast lesions, but they're interesting breast lesions. They are an abnormal collection of tissues which are normally present within the breast. If you biopsy them, the pathologist will give you a report of normal breast. Mammographic finding has no associated clinical findings and has normal histology. These should not be palpable, or if they're palpable, they should be very, very, very subtle. If they're associated with a discrete, dominant palpable mass, they are not a hamartoma. The outer stromal rind, there's an outer stromal rind and areas of fat and soft tissue within the lesion, and the classic description has been that of a slice of sausage. The diagnosis can be made on the basis of the mammogram, and biopsy is not necessary. And here you see a hamartoma that's subareolar in this patient. You can see that there's cleft. There's this cleft of fat. We really can't see the outer stromal margin to it. And then inside it, there's fat and soft tissue density that are commingled. Now, ill-defined masses containing fat include asymmetric tissue, hematomas, infiltrating lobular carcinoma. Asymmetric breast tissue is a common finding on the mammogram, and it is not unusually a cause of difficulty for people who are interpreting mammograms. The important things to remember about asymmetry are that, first of all, it's not palpable. Or if it is palpable, it should feel like normal breast tissue, and it should be very subtle. It shouldn't be palpable as a discrete focal mass. When we look at it on the mammogram, one of the criteria that I use is, I think if the woman had a mastectomy and we didn't have her other breast, would I even notice that anything is present on this mammogram? Because it looks like normal breast tissue. And that means it has the density of normal breast tissue, it has concave margins like normal breast tissue has, and it has no mass effect on adjacent structures. This is as opposed to true masses that can look like asymmetric breast tissue, and they may have an associated palpable mass. In fact, they often do. They do have a mass effect that's apparent on adjacent structures with displacement of those structures. And if you have a hematoma causing the mass, then you usually have a history of trauma inciting the hematoma. Again, normal breast tissue is isodense, concave margins. It has no findings that go along with cancer. So it doesn't have calcifications that make you worry about cancer. It doesn't have those secondary signs of malignancy we talked about. And again, it should not be palpable as anything worrisome. It does become worrisome if it's palpable, if it has secondary signs, if it has mass effect, and if it has calcifications. This is a woman who has more density in the upper outer quadrant of her left breast than she does on her right breast. You can see that this margin is concave, this one's kind of straight, but this is concave. You can see that there are normal structures intimately associated with part of its margins, but it's not pushing on those structures. It's not disrupting the course of those structures at all. If we examine this patient, which we do when we do a mammogram and it looks like this, we don't feel anything up here either. So we're comfortable that this falls into the area of asymmetric breast tissue. What we usually do with these women is if we can't get an old mammogram, we'll do a short-term follow-up, a 6-month follow-up on this side. Then she's back to her bilateral mammogram on the other side, and we put her back into the screening study, making sure she comes back for 3 years so that we can follow it. So that's how we deal with this. Skin lesions are commonly seen on the mammogram. Your technologist will often tell you that it's there ahead of time when she looks at the patient before she does the mammogram. But if they're not there, there are hints on the mammogram that they represent skin lesions, and that all you have to do is go back and take a look at the patient if you don't know it's a skin lesion already. They are well defined. They are obvious on inspection and examination. They can be confirmed by using skin markers. And since they're a bump on the skin, when we compress the patient, there is often air that is trapped between the skin lesion and the skin itself, so we get a radiolucent halo due to air around the lesion. And here are 2 different skin lesions that were obvious on examination of the patient. This is a CC view, craniocaudal view of a patient, and you see this very well-defined, very well-demarcated lesion. And you see how it's real lucent around it from the air that's trapped between this and the rest of the mammogram. This was an accessory nipple that was in the inframammary fold deep in the 6 o'clock axis. This is a patient who has this band running across the top of her breast, and again, the same kind of radiolucency that you see here, you see over here, and this is a keloid. Now, of the common lesions that we see in the breast, the 2 common lesions we see in the breast that are benign are, of course, cysts and fibroadenomas. Cysts are common in women in their late 30s and their 40s, although they may be present in women in any age, and they are also common in postmenopausal women now that there's so much exogenous hormone replacement therapy that's being done. They are, although we think of them often as solitary lesions, they are not uncommonly multiple and clustered. They may be septated, and they may be unilateral or be bilateral. Again, they can occur in postmenopausal women as well as premenopausal women. And the diagnosis is not made on the mammogram. The diagnosis is made by doing a sonogram or doing an aspiration. Now, cysts, of course, are filled with fluid, so they are water density, and they look the same as other water density masses do on a mammogram. And this is a woman who you can see has this big mass up here, and she has the second mass here. Its margins are not really well defined. Some of them are, but some of them are obscured by adjacent tissue, and 2 of them, at least 2 of them here. We cannot make the diagnosis of this being a cyst on the basis of the mammogram. So what we do is we go ahead and do a sonogram unless it's palpable and the surgeon wants to just aspirate it to determine what it is. And on the sonogram in this particular case, we saw this, and we saw this, 2 obvious cysts. The criteria for a simple cyst are that it's round or oval, it has a thin wall of uniform thickness, and it has an absence of internal echoes. If it doesn't meet these criteria, then it is not a simple cyst. And I think Dr. Bassett's going to talk a little bit about ultrasonography later, so we'll skip over the rest of that. Fibroadenomas, the other very common lesion, benign lesion that we see in the breast, are often well-defined, rounded. They may be somewhat lobulated. We see them in young women. The age is younger than that for which we see cysts. They are not distinguishable mammographically unless they have these typical coarse, clumpy calcifications that we see in a degenerating fibroadenoma, which is why we have to biopsy a lot of them. The association of calcifications with breast masses is very important. And you have to look for them. Obviously, you do look for them. And you have to look for them whether they're the coarse, clumpy ones or the fine ones. Because the coarse, clumpy, benign calcifications tell us that a mass is a benign mass and doesn't need any further workup. These pleomorphic, ugly-looking calcifications make us very worried that a mass is a cancer and make us more anxious to get some tissue sampling. Now, other kind of non-focal masses, more diffuse masses that are in the breast, include the breast with unilateral increased density. And the differential for this includes the irradiated breast, a woman with mastitis, with inflammatory carcinoma, with lymphoma, or with obstructed drainage, either lymphatic or venous compromise. And here's a woman who is okay on her right side. These are her CC views. And on her left side, you can see that the entire breast has increased density compared to this side. All these little lines here, which are the breast stroma, are exaggerated. All the breast tissue, the glandular tissue here, has increased in density. And if we could see the skin, which is burnt out on this slide, we'd see that the skin is thickened also. She obviously also has something inside the breast. She has this large mass inside the breast. This is inflammatory cancer in this particular patient. But if we took away this and just looked at the rest of it, the differential is, as I stated already, some of the differential can be narrowed down on the basis of the patient's history. Some of it cannot. Now let's look at what are perhaps the most interesting masses that we see sometimes on a mammogram, and those are spiculated breast masses. These are very suspicious for carcinoma unless they correspond definitely to a site of prior surgery. Spiculated masses may be actually not even real. They may represent a summation shadow, and they need to be appropriately worked out to be certain that they don't represent overlapping tissue. The benign lesions which can cause a spiculated mass include the postoperative scar, radial scar, fat necrosis, sclerosing adenosis, extra-abdominal desmoid, and abscess. Malignant primary breast cancers also cause spiculated masses, and that is what this particular lesion is. Summation shadows, when they're causing a spiculated mass, are often evident only on one view, and what we do to evaluate them is do a compression spot over the lesion to determine whether or not it persists. Now here's a woman who on her CC, her craniocaudal view, has this lesion. Now when we do a compression spot, if it's a real lesion, the normal breast tissue gets pressed away, and the mass itself, if it's a real mass, remains prominent or becomes more prominent vis-a-vis the surrounding tissue. So this is what it looked like before, and on compression this is what it looks like. Is it real or is it not real? It's real because the tissue around it has pressed away, all this stuff has pressed away, and this ill-defined thing in the middle, this thing, is still present. So that's a real lesion. Now this is a woman who came in, and on this view she has this dense-looking thing with these spicules extending out from it, really looking terrible. It was only seen on one view, so again we do a cone compression view with a small spot compression paddle, and we push it down, and what happens? It's gone. There's nothing there anymore. So this is a summation shadow, and they're very easy to work up, and you certainly don't want to biopsy a summation shadow. Now, post-surgical scars are perhaps the most spiculated mass that we see on the mammogram. And post-surgical scars may be better seen on one view than on the other view. They may contain fat centrally. They may be more prominent as post-surgical edema resolves if you're following them after the acute post-surgical period. They may be associated with the deformity and scarring in the skin that's due to the surgery. They do not enlarge with time, and you may not always be certain that it is a scar that you're looking at, and if you're not certain, then you can't exclude a carcinoma. This is a preoperative cone compression view on this spiculated carcinoma, and postoperatively what she looks like is she has skin thickening, looks kind of like that keloid did that we looked at as a skin lesion before. She has a double contour to the breast because of the deformity in the contour, double margin to the breast because of the deformity in the contour from the surgery, and she has this ill-defined mass here. Fibrotic stranding goes up to the skin and extends around the area, which represents the scar. It exactly corresponds to the site on the preoperative mammogram where her lesion was. So that's scars. Fat necrosis can appear as spiculated masses. And this is an inflammatory reaction to the damage of fat cells that can produce sometimes a palpable mass or a mammographic mass without clinical findings. As well as a spiculated mass, it can appear as oil cysts or calcifications. A preceding history of trauma is not always present. Mammographically, they may appear identical to carcinoma, and sonographically, they may also appear identical to carcinoma. And here is an ill-defined spiculated mass that was fat necrosis. Radial scars are very interesting lesions. Classically, they contain fatty centers and broad radiating bands of fat and breast tissue with a palpable mass. Microcalcifications, it's important to remember, may be present in about 1/3 of these lesions. So the presence of microcalcifications doesn't exclude a radial scar. Histologically, they're areas of hyalinizing fibrosis and elastosis with entrapped ducts, and often they're smaller histologically than they are mammographically. The literature suggests that they may have a significant association with breast carcinoma, especially of the tubular type. This is controversial. If there is an associated carcinoma, it's usually not in the center, but it's more peripherally located, meaning the excision of the lesion needs to be a wide excision of the lesion. They cannot reliably be differentiated from malignancy without a biopsy, so these need to be biopsied. And the classic appearance of a spiculated carcinoma we see here. It's dense, it has infiltrating margins, very poorly marginated. Now, what do we do when we see a dominant mass on the mammogram? If it's solitary and if it's well-defined or slightly irregular, we sono it. If it's a cyst, we're done. If it's solid or we don't see anything, then we have to figure out how worried we are about it. If we know it's a scar, we don't have to go through all of this and work it through. If it's spiculated and not a scar, it needs a biopsy. If it's solid and irregular, it needs a biopsy. If it's smooth and it's small, you may want to just do short-term follow-up. If it's smooth and it's large, you need to do a biopsy. When you're assessing size, however, I would remind you that screening studies indicate that the intervention of mammography in saving women's lives from breast cancer is effective because of the diagnosis of cancers that are 1 centimeter in diameter or smaller. So don't watch something grow to 15 millimeters before you take it out. Intervene when it's at a size where the intervention will make a difference. If there are multiple lesions that are present within the breast, then you have to assess whether they are all of the same configuration, and we're not talking about multiple spiculated lesions, but if there are multiple lesions in the breast that are reasonably well defined, if they all look like they're due to the same kind of process, then we follow these often with short-term follow-up, the way we spoke about earlier, to make sure that they're all doing the same thing and one of them is not getting bigger while everything else is staying the same or getting smaller. And if they're not all the same, and if there's one in that bunch that's worrisome, then you need to treat that as if it were a solitary lesion and go through the solitary lesion algorithm. Thank you for your attention.